Good afternoon, everyone, and welcome to the online public talk on women's cancer. I'm Pei Xian from 365 Cancer Prevention Society, your host for today. This talk is brought to you by Singapore Society of Oncology, supported by 365 Cancer Prevention Society, and sponsored by AstraZeneca, Bayer, Merck, and Sanofi. As attendees in these webinars, your mics will be turned off. During the presentation, should you have any questions, please send your questions in the Q&A tab at the bottom of your Zoom application. Our first speaker is Dr. Lim Sheow Lei, a senior consultant medical oncologist at OncoCare Cancer Centre. Her clinical expertise includes the management and treatment of gynecological cancers, such as cancer of the ovary, uterus, cervix, and vulva. Today, she'll be sharing with us a topic on cervical cancers, prevention, and treatment. So without further ado, let us welcome our first speaker, Dr. Lim.
Yeah. Okay. Thank you. Okay. Thank you, Pei Xian. A very good afternoon, everyone. Thank you for attending this talk on women's cancer. I'm Dr. Lim Sheow Lei. I'm a cancer doctor with a special interest in the treatment of women's cancer. Women are by nature carers and providers. We can provide for our children, our spouse, as well as our parents. In the midst of all this, we may sometimes ignore our own health. To make matters worse, the COVID pandemic has shifted a lot of focus towards the COVID itself and away from other health-related matters. And during the last 2 years, there are actually women who actually put on hold their healthcare and cancer screening. And worse still, there are some women who have actually not well, have symptoms, but yet delay going to see a doctor because they are more concerned about the COVID. With the COVID now becoming more of an endemic, I think it is time for us to refocus on cancer prevention. And today I'm going to talk about cervical cancer. Cervical cancer is a very, very preventable cancer. And part of my talk, I'm also going to talk about how we treat this type of cancer. This is the female reproductive organs, and these are situated at the lower part of the abdomen, also known as the pelvis. It consists of 2 ovaries. In the middle is the uterus, or otherwise known as the womb. This is the part, where the baby is being housed when the woman is being pregnant. The cervix is the structure that is located at the lower end of the uterus. It separates the uterus from the vagina. And cervical cancers are cancers that starts or begins in the cervix. Globally, cervical cancer is the 4th most common cancer in women worldwide. And cervical cancer disproportionately affects women from low and middle income families, as shown in the darker shades of red. In Singapore, the number of cases of cervical cancer has declined over the last 50 years. Back in the 1970s and 80s, cervical cancer used to be the 4th most common cancer affecting Singapore women. Currently, it's the 10th most common cancer. And this decline coincided with the introduction of pap smear screening in Singapore back in the 70s and 80s. We think that women are actually more aware of cervical cancer now, and more women are coming forward for screening. However, any life that's lost to cervical cancer is one too many, because this is a highly preventable cancer. In fact, more than 90% of cervical cancers can be prevented. And this can be done in 3 very simple steps. Number 1, avoid the risk factors. Number 2, vaccination. And number 3, go for screening. Nowadays, when we talk about viruses, the number 1 virus that comes to our mind is the COVID virus. However, there's another virus that women need to know about. That is the HPV virus. HPV infection is the number 1 and the most important risk factors for cervical cancer. This virus is spread through sexual contact, meaning to say that any woman who is sexually active or has had sexual experience is at risk of catching this infection and therefore at risk of cervical cancer. The risk is higher in women who actually had the early sexual debut or that they have multiple sexual partners. Women who has a weakened immune system are less likely to be able to get rid of this virus, and therefore they are also more at risk. These are women with HIV infection or women who are on medications to suppress their immune system, such as women who has undergone organ transplant. Smoking also double the risk of cervical cancer because the tobacco smoke can damage the cervix, resulting in a higher risk of cervical cancer. HPV stands for the human papillomavirus. Almost all cases of cervical cancer is in fact caused by HPV infection. As we said earlier, it's spread by sexual contact, and it is extremely common as the common cold. Most sexually active women will be infected by this virus at some point in their life. For majority of these HPV infections, it's largely silent. It occasionally can cause genital warts, but most women who has this infection are not aware of it. The good news, however, is that majority of women with HPV infections do not develop cervical cancer. This is because there are many different types of virus. There are in fact more than 200 different types, and only about 15 or 16 are cancer-causing. And we call these cancer-causing HPVs the high-risk HPVs. Majority of the time, our immune system is able to get rid of these infections. Problem only arises when we have a persistent infection with the high-risk HPV, right? And this will actually increase the risk of cervical cancer. Besides cervical cancer, HPV can also cause other types of cancers, such as vulvar and vaginal cancer in women, penile cancer in men, anal and oral cancers in both men and women. But unlike cervical cancers, these other HPV-related cancers, there are no effective screening. Therefore, prevention of the HPV infection is very important. Okay, about 15 out of the 200 strains are cancer-causing, but there are two strains that we need to be aware of. These are the HPV-16 and HPV-18. And these two viruses, or two strains of viruses, are the main culprits. Together, they cause about 70% of cervical cancer. And being able to identify these two viruses was actually very important because it actually paves the way for scientists to develop vaccines for the HPV. The HPV vaccines actually make use of proteins from the outer layer of the HPV virus. This actually tricks our body immune system to think that we have gotten the HPV infection and therefore will develop antibody against it. All right. This vaccine does not contain any live viruses, so you will not actually get an infection through vaccination. It is quite effective in preventing HPV infection. However, if a woman has already contracted the virus infection, this vaccine is not going to be able to treat it. When we think about vaccines, we also need to think about the safety. HPV vaccine has been around for quite a while. It's been around since 2007, so a good 15 years, and has got quite a good safety records. There are three types of HPV vaccines: Cervarix, Gardasil, and Gardasil 9. All of these three vaccines prevent HPV-16 and HPV-18 infections, which are responsible for 70% of cervical cancer. Gardasil 9 is the newest of these three vaccines, and it actually offers a wider coverage. So besides HPV-16 and 18, it protects against an additional 5 different types of subtypes of the HPV viruses, and its level of protection is up to about 90%. Gardasil 4 and Gardasil 9 also protect against HPV 6 and 11, okay, and therefore protect against genital warts. Okay, so many women, after they have received their HPV vaccination, wonder whether or not they need to continue their cervical cancer screening. The answer is yes. This is because although the vaccine is quite effective, however, the protection is not going to be 100%. HPV vaccine offers the best protection if this is given before a woman becomes sexually active. Because this is a preventative vaccine, it does not help to treat an existing infection. The Singapore National Immunization Program recommends HPV vaccination for females aged between 9 to 26 years old, which means that women above the age of 26 has actually missed out on this vaccine. But is it too late? Recent studies showed that Gardasil 9 vaccine actually helps to protect HPV infection up to the age of 45. Some women may wonder, if I actually start getting this vaccine at the age when I'm already sexually active and has likely to be exposed to this virus, is there a use? The answer is that because there are many different types of strains of HPVs, chances are that even you have been infected with 1, 2, or 3, you wouldn't have been exposed to all the different strains. Therefore, the vaccine can still protect against HPV infection that you have not been exposed to. So in September 2020, Health Sciences Authority of Singapore expanded the use of Gardasil 9 to include females from age 9 to 45. And this Gardasil 9 is also FDA cleared. However, the recommendation is to get the vaccine as early as possible, right? Because that's when you're going to get the best protection. Cervical cancer is a cancer that takes time to develop. It does not develop overnight, and very often it takes many years. Okay, this is what a normal cervix looks like. In 90% of the time when it's infected with the HPV, it can clear it. Our body immune system will be able to clear it. It is only when it gets a persistent infection with the high-risk type of HPV, then this may then develop into what is called a cervical precancer. If untreated, this precancer may then become cancer. Okay, cervical precancer is also known very commonly as CIN. Most of the time, it is very silent. The only way to pick it out is through screening. This is what a pap smear of a CIN looks like. The cells are very large and bizarre looking compared to the normal cells. The good thing is that the cervical precancer phase is a very long phase, right? On average, this will last for about 15 years or even up to 20 years, right? Which means that there's a lot of opportunities for doctors to actually pick up this precancerous phase, right? And once it's picked up, we can then treat it. Treatment involves only a local treatment, and the lesions can actually be burnt off, right? And you get to keep the cervix and you get to keep your uterus. Okay, so there are two types of screening tests. Okay, pap smear, which I think more people are familiar with, but there's also a new type of screening test called the HPV test. Okay. So to conduct a pap smear, the doctor will conduct a pelvic examination. Then he or she will use a soft brush to remove some of the cells from the cervix. This will then be sent to the laboratory for analysis to check for abnormal cells, okay, and precancerous changes. This procedure is a very simple procedure, takes a few minutes, generally very painless. It may be a little bit uncomfortable, but generally not painful. Okay. The HPV test is a newer test for women. It tests whether a woman has been infected with the high-risk type of HPV viruses. It is more accurate than pap smear. Women with high-risk HPV infections may have normal pap smear, all right? And it is only recommended for women above the age of 30. This is because many women under the age of 30, we have a more intact and robust immune system. And most of the time, we can get rid of this infection spontaneously, right? It is performed in the same way as we do a pap smear. This is the HPV vaccination schedules in females. Women above the age of 15-year-old require 3 doses of the vaccines over a space of 6 months. Those between the age of 9 to 14 only require 2 doses because the younger you are, the more robust your immune system is. So you don't need so many doses. Females aged between 9 to 26 can choose to receive either the Cervarix, the Gardasil 4, or the Gardasil 9, whereas women above the age of 26 can only go for the Gardasil 9. All right. In Singapore currently, the Gardasil 9 is actually not covered by MediSafe. All right. It is you have to pay out of pocket. And this is the cervical cancer screening schedule. Okay, women who ever had sex need to start cervical cancer screening beginning from age 25. The pap smear is done in this age group every 3 yearly as a minimum. Some women may even choose to do the test more frequently, every 2 yearly or sometimes even yearly. HPV testing is not recommended in this age group for the reasons I stated earlier. In women above the age of 30, right, there are 2 tests they can choose. They can either go for the HPV test or the pap smear. But HPV testing is the preferred method because number 1, it is more accurate than a pap smear. Number 2, you only require to do it every 5 yearly instead of the 3 yearly pap smear. Okay. So just to have a pause here, Pap smear as pap smear screening, HPV testing, as well as HPV vaccination is widely available in Singapore in the polyclinics, in GP surgeries, as well as in private clinics. The Singapore government is very keen to encourage women to come forward for such testing, and therefore there's a series of subsidies available. For more information, you might need to check the Singapore Cancer Society website to know whether or not you're entitled to these subsidies. Okay, so now I'm going to move on to talk about cervical cancer. The most common age whereby we see women with cervical cancers are women aged between the age of 40s to the 60s. However, you can see them in young women as young as in their 20s and old ladies in their 80s as well. Early cervical cancer may not have any symptoms or any signs, and therefore the importance of going for screening. Okay, some of the symptoms that women may notice or complain of are abnormal vaginal bleeding. Okay, this is where the cancer is. So this could be bleeding after intercourse, between menstrual periods, and in older women after they have already reached menopause. Women may notice blood-stained vaginal discharge or foul-smelling vaginal discharge. They may also notice discomfort or pain during sexual intercourse or complain of pelvic or back pain. For most women who have all these symptoms, most of the time this is not due to cervical cancer, but it's important to get this checked by a doctor to make sure that this is not. Okay, if a doctor suspects cervical cancer, you will need to undergo a colposcopy. Now, this is a colposcope. This is actually an instrument that has got a magnifying lens. This allows the doctor to have a good and clear view of the cervix. This is what a normal cervix should look like. This, unfortunately, is a very abnormal looking cervix, very suspicious of cervical cancer. However, we cannot diagnose cervical cancer just by how it looks, all right? We need to take a small piece of tissue and send for further tests. This is what we call a biopsy, okay? So in the laboratory, the doctor will look under the microscope, all right? Number one, this will help to confirm whether or not this is indeed cervical cancer. And number two, if this is cervical cancer, depends on what they look like, they can tell the type of cervical cancer. There are two main types of cervical cancer. The more common one is the squamous cell type, and a less common, the adenocarcinoma. Both of these cancers are treated in very similar manner. There are less common subtypes such as lymphomas and neuroendocrine cells. These are very, very rare indeed, and they require a different type of treatment. Okay. Once the cancer diagnosis is confirmed, we then need to determine if the cancer has spread. This involves a physical examination and also imaging scans such as an MRI scan to look at the pelvis and also body scans. Okay. Like many other cancers, cervical cancers has got 4 stages: 1, 2, 3, and 4. For stage 1 cancers, these are briefly cancers that's limited still in the cervix. Stage 2 and stage 3 cancers have gone and spread outside the cervix to involve the organs in the pelvis. Stage 4 cancers have gone beyond the pelvis to affect more distant organs, such as the lung, the liver, or the bones. In Singapore, 2 out of 3 cervical cancers are discovered when they are still stage 1 and 2. So that's actually very good because the cancer outcome and after treatment tends to be very good. Okay, so how do we treat cervical cancer? Cervical cancer is a very treatable cancer. A cancer diagnosis nowadays is no longer a death sentence, right? The earlier you see a doctor, the earlier diagnosis is made, the better is the outcome. Very broadly speaking, when we think about treatment, we need to take into account the stage of the cancer, and also to fine-tune treatments, we need to think about the type of cancer that we are dealing with, and also take into account a woman's overall health and their preference. For early cervical cancer, so these are the stage 1 cancer and some of the early stage 2 cancers, the main treatment is to do a surgery and remove the cervix where the cancer is, remove the womb, and maybe some of the nearby lymph nodes. After the cancer has been removed, this will be sent to the laboratory for analysis, and following which, the doctor will be able to recommend, based on the characteristics of this particular cancer, whether further surgery, further treatment such as radiation or chemotherapy will be required. The outcome when treated properly for these early stage cancers are very, very good and excellent. And many of this, or most of these women will get cured. Although surgery is a very good way of curing cervical cancer, but it does make a woman infertile. They can't have any more children. Increasingly, we are seeing women in their 30s with cervical cancer who has not completed a family. So in some of these people with very early stage, very small early stage cancers, it may be possible that we can actually perform what is called fertility sparing surgery. So whereby only a small piece of the tissue is being removed around the cervix area and maybe the vagina area. The womb is actually not removed, it's being kept intact, and the ovaries are also kept intact, and this allows women to get pregnant. So for stage 2 or stage 3 cancers that spread to the pelvis, we call this the locally advanced cancer. The main treatment is in fact radiation treatment, whereby we shine a very high dose of X-ray at the cancer to kill the cancer cells. And we also know that by adding in some chemotherapy to the radiation makes the radiation work a lot better. Right? This chemotherapy are low dose chemotherapy and does not cause hair loss. Very well tolerated. All right. So even with locally advanced cancer, we are still aiming to cure the cancer. Okay. About 15% of women in Singapore at the time of diagnosis, unfortunately, has advanced stage 4 cervical cancer. These are cancer that has spread to further organs, right? To treat this type of cancer, we need a drug therapy because the drug therapy can go around the body and reach different parts of the body when the cancer has actually spread to. Okay, so I'm going to focus the next few minutes on how we treat advanced cervical cancer because there have been quite a few exciting and new advances in how we treat this type of cancer. Okay, so in terms of drug treatment, the most common or traditionally the type of treatment that we use to treat advanced cervical cancer is chemotherapy. But there are now newer non-chemotherapy treatments available, such as targeted therapy and immunotherapy. Chemotherapy is the use of drug treatment to kill fast-growing cells in our body, such as cancer cells, because cancer tends to grow faster. One of the problems with chemotherapy that many people fear about is the fact that besides killing the cancer, it may also cause collateral damage to the other healthy cells in our body, especially the ones that grow faster. The good news is that newer generation chemotherapy drugs are, number one, works better than the old drugs. Number two, they are also better tolerated. Additionally, doctors are also better in preventing the side effects of chemotherapy and managing side effects. So majority of women who undergoes chemotherapy for cervical cancer can go through it without too much problem. Nevertheless, chemotherapy is not a very precise form of treatment. When we think about drug treatment for cancer, ideally, we want a drug that's able to target the cancer better so that it will make the treatment more effective. Number two, is less likely to cause harm to the normal cells in our body. This is what we call precision cancer treatment. We now know that every cervical cancer is unique. No two cervical cancers are the same, even though they may look the same under the microscope. Each tumor has a unique set of proteins or gene defects that's making the cancer grow and spread. And this can be targeted by specific drugs so that the cancer stops growing. Right? This type of drugs are very different from chemotherapy, and it tends not to cause the traditional side effects of chemotherapy, such as hair loss, nausea, vomiting, or a lowering of the immune system. So this is a small cancer cell here. For it to grow, to become bigger, it needs nutrients, right? And it depends on blood vessels to bring these nutrients to it, to feed its growth. So a lot of times cancer cells will have to develop its own network of blood supply. And they make use of this protein called the VEGF protein to build up the blood supply. So there are drugs now that can actually block or target this VEGF protein. And in so doing, it stops blood vessel formation and therefore results in the cancer cells starving to death because of a lack of nutrition. Example of such a drug is a drug called bevacizumab. Otherwise, I think most people know it better as Avastin. And this drug can be used in the treatment of cervical cancer. Okay. Next, I'm going to talk about immunotherapy. Immunotherapy is, I would say, a new and also very exciting type of drug. It's drug therapy that energizes or boosts our immune system so that our immune system can recognize and fight cancer better. So our immune system normally will be able to recognize what is part of our body and what is actually foreign. All right, it's able to defend and fight against or fight off foreign invaders such as viruses, bacteria, and including cancer cells. However, cancer cells can be very cunning and sly. It can find ways to hide from our immune system. And one of the ways it can do so is to produce a protein called the PD-L1 protein. Now, this PD-L1 protein from the cancer cell will bind itself or join itself to another protein called the PD-1 on the immune cell. Right? When this happens, it sends a signal to our immune system to tell the immune system that, hey, I'm one of you guys. Please do not attack me. Okay, so doctors have now and scientists have now come up with drug treatment that can actually block and prevent the PD-L1 from binding to the PD-1. So when this happens, the immune system can, the cancer cells can no longer hide, and the immune system can then recognize and attack the cancer. This type of drug are called immune checkpoint inhibitor, and it's found that cancer cells which contains this PD-L1 protein are more likely to benefit from this type of treatment. These treatments are given as very short infusion drips in the clinic once every few weeks. Okay. So this is a patient of mine. She's a 38-year-old woman, which unfortunately has recurrent cervical cancer. So she came to see me for a second opinion. All right. At the time when the cancer has come back or recurred, it unfortunately has gone to the pelvis, to the lungs, and also to the bones. You can see this is a fairly large size cancer in the pelvic area, and not surprisingly, this woman was in a lot of pain. All right, and we checked this tumor, it actually does contain the PD-L1 protein. In the past, traditionally, we used to give this type of patients just chemotherapy. Now, recent studies have shown that if you add in immunotherapy to the treatment, the result is actually better. So this is what happened 6 months later after we have given her treatment, right? The cancer has completely disappeared from the scan. And we repeated the scan 12 months later, the cancer has not come back at all. Immunotherapy is quite a bit of a game changer in the treatment of cancer, including cervical cancer. It can make the cancer control better in patients with advanced cancer, not only better, but also control the cancer for longer periods of time. Right? In other cancers, such as lung cancers, we know the control can be as long as months and sometimes even years. And the reason we think this is the case of this prolonged cancer control is the fact that the immune system has actually quite a good memory. It actually kind of remembers these foreign invaders, such as the cancer. It's a bit like saying that once you get measles, you don't get it again because the immune system protects you against it. So when times, maybe months or years later, when the cancer tries to grow back again, the immune system can still try to suppress it. As we said earlier, chemotherapy is not a very precise form of treatment, but can we make it target cancer cells better? We know that about 90% of cancer cells contain a protein called the tissue factor, and this protein is found on the surface of the cancer cell. There is now a new drug called tisotumab vedotin, or TV in short. Now, this drug actually has got two parts to it. The first part is in green, called antibody part, and the one in orange is the chemotherapy part. The antibody part recognizes the tissue factor, right? So when it encounters the tissue factor, it will stick to it and binds to it. That helps us localize where the cervical cancer is. And when this happens, the chemotherapy we get released into the cervical cancer cell. Right inside the cervical cancer cell, the chemotherapy can directly kill the cell. So this is a new type of treatment for cervical cancer. And I think we are making progress in the way we treat these women with advanced cervical cancer. And women are living now twice as long as they used to because of all these treatment advances. And therefore, I urge women with advanced cervical cancer, okay, not to give up, okay, and don't give up hope, because there are new treatments and the treatment outcomes are a lot better now. Okay, I'm coming to the end of my presentation. All right, prevention is always better, and we hope that we can empower women, okay, to take stock of their own health, all right, to protect themselves from cervical cancer better. Okay, it is a very preventable cancer. It is a very detectable cancer. Okay, in women who has got symptoms that may be suggestive of cervical cancer, please go and see a doctor early, right? Because this is a very treatable cancer. And even with women with advanced cancer, don't give up hope, right? There are a lot of new treatment advances, which is actually going to make a difference and improvement in how far we can treat this type of cancer. Okay, so with this, I'm going to end my talk. All right, thank you for your time, and I'll hand the time back to Pei Xian.
Okay. Thank you, Dr. Lim, for the insightful sharing. And next, we have Dr. Tan Sing Huang, Senior Consultant Medical Oncologist at OncoCare Cancer Centre, who has more than 20 years of experience in managing a wide range of cancers with a special interest in breast cancer management and treatment. She was also previously a senior consultant at National University Cancer Institute, Singapore. Today, she'll be sharing with us a topic on everything you want to know about breast cancer and more in a nutshell. So let's welcome Dr. Tan.
Yeah. Hi, everyone. Thank you for attending our talk today, this afternoon. And the topic from myself is breast cancer. And I will be covering everything from the basics of breast cancer to what is the latest treatment. So for breast cancer, it is the most common cancer in females. And this number one cancer, the second being colon, and followed by lung cancer. Just in the past 5 years, 2015 to 2019, there have been 235 cases of cancer per 100,000 in the population, and for which breast cancer forms the most common cancer. This is just a table to show you the how it actually fares in terms of the most common top 10 cancers. And you can see in the age group of in the 20s that breast cancer is not the most common cancer. In fact, it is the fourth most common cancer. But as you move on to the 30s, 40s, 50s, 60s, and 70s, breast cancer then becomes the most common cancer. And then in the 80s, it drops to the second most common cancer after the colon and rectum cancers. The most common stage that breast cancer is detected is stages 1 and 2. And breast cancer is detected in 1 in 13 women locally in their lifetime. The survival rate for breast cancer actually fares quite well compared to the other cancers, for example, colon, lung, as well as the uterus. And you can see that these are the Singapore statistics, that 5 years after diagnosis, it is approximately an average survival rate of 82%. Breast cancer starts increasing in frequency from the age of 30 onwards, reaching a plateau of about in the 60s to 70s, and then a gradual decline. However, it is heartening to see that if you detect breast cancer earlier, particularly in the earlier stages, for example, stages 1 and 2, that the survival rate of cancer actually is much better. And although it is not shown on this slide, if you detect it at stage 0, which is a stage where the breast cancer cells have not become invasive, meaning that they do not have the ability to spread to other areas, that surgery alone or surgery with radiotherapy and then just some oral medicines actually will suffice, and the doctor will usually not talk to you about chemotherapy. So earlier detection is the key. And if you detect it early, your treatment will be simpler. So breast cancer, a number are actually being detected by screening. And very often women nowadays may come in with a normal mammogram, but we do see a fair number who still present with a palpable lump in the breast. And there are others who may present with other symptoms such as nipple discharge, particularly a bloody nipple discharge, or nipple changes such as retraction or ulcerated skin. And these are more advanced cancers. Already some people may present with a mass in the armpit, but not in the breast. And this is a rarer presentation where it can present just with lymph nodes that are enlarged in the armpit. Hence, we have to try and pick up any suspicious symptoms earlier, and this starts with breast self-examination. Breast self-examination can be done about once a month, at least a week after your period, and it is a good habit to adopt this. Breast examination usually begins in your 30s, and it's good to start earlier because then you get a feel of what is normal and what is not. You've all heard about mammograms. A mammogram is our national screening, one of the modalities which is encouraged for all women to go for a mammogram. And this is a simple low-dose X-ray examination, and there's newer techniques known as digital breast tomosynthesis, where it makes use of 2D or 3D images, which is actually very good for dense breasts, and you can pick up lumps easily, and the recall rate back for for suspicious lumps is less. And this can usually start at the age of 40, and 40 to 49, we would do it once a year, and 50 onwards once every 2 years. An ultrasound is actually used to pick up abnormalities seen in the mammogram, and it is not used as a substitute for mammogram. Although a lot of people may ask about this because they are scared of the radiation exposure from a mammogram. But rest assured, the radiation exposure in a mammogram is very, very little, and it will not be enough to cause cancer. MRI breast is another modality which can be used to pick up breast abnormalities. I have to emphasize this is not a modality for screening in general, in the general population. But however, if you do have any predisposition to a high-risk incidence of breast cancer in your family, or you have any hereditary syndromes in your family, or plus yourself, then MRI breasts plus mammograms would then be used in combination for your particular breast cancer screening. If the doctor finds an abnormality in the breast, then they will use a directed needle to actually core out a sample of the breast tissue in order to sample the lesion of interest to see whether or not it is cancer or benign. So breast cancer begins in the breast tissue. It actually may start in the milk duct or lobe of the breast. And when the controls in your breast cells are not working properly, they may divide continually, forming eventually a tumor. As mentioned before, cancers that cannot spread to other areas, cannot run to distant sites, are called in situ cancers. And cancers that can spread to other distant areas, meaning it can spread to your liver, your lungs, your bones, are called invasive cancers. And these are what I referred to earlier as stage 1 to 4 cancers. Now, reassuringly, although women have some lumpiness in the breast, most breast lumps are benign, meaning that they are not cancer. So this diagram just shows you the main parts of the female breast. You have the lobules, which are the milk-producing glands, the milk ducts, as well as the fatty tissue and ligaments surrounding the ducts, the lobules, the blood vessels, and lymphatic vessels. So most breast cancers begin in the ducts, which are ductal, and some begin in the lobules and the rest in other tissues. So each breast is surrounded by a network of lymphatic channels as well as lymph nodes. And lymph nodes are actually small bean-shaped collection of immune cells connected by lymphatic vessels. And these contain your waste products and your immune system cells. What's so important about them is that cancer cells can actually enter the lymphatic system and they start to grow in the lymph nodes, which then become enlarged. And when that happens, you know that it is of higher chance that perhaps your cancer has gotten into your bloodstream and spread elsewhere. So hence, once again, the importance of early detection. Now, breast cancers, when they are diagnosed, the lab will always run 3 protein assays on your tumor, 2 of which are known as estrogen receptors and progesterone receptors. And these are protein receptors that are present on breast cells that attach to your estrogen and progesterone, which are intrinsically in your body. And they run the third protein known as HER2. HER2 is actually a protein which receives growth signals from within your body and causes the cell to grow more aggressively. Based on these 3 proteins, your breast cancer can be subdivided into 3 subtypes. Hormone receptor positive subtypes, where the ER or the PR expressions are positive, and this forms the majority of breast cancers. HER2 positive tumors, where the HER2 protein is actually amplified, and this forms about 15 to 20% of cancers. And then triple negative cancers, where all 3 protein assays are negative. Of these 3, the HER2 positive and triple negative cancers are the most aggressive. So what's the treatment process for resectable invasive breast cancers? So for breast cancer, usually if it is found at an earlier stage, it can be resected first. And after surgery, we may give treatments such as chemotherapy, targeted therapy, radiotherapy, or endocrine therapy for reducing the risk of recurrence, as well as prolonging the survival. Why, you might ask, that after surgery, would you need all these treatments when it's already removed? The reason is because sometimes there are stray cells, which we call micrometastatic disease, that is hiding in the rest of the body. And these treatments are meant to try and mop it up, and hence, hopefully, we will not be seeing you again for a recurrence in later years. Now, sometimes patients present with tumors that are larger, or tumors that may respond very well to treatment, and the patient may want have a chance to conserve the breast and not remove the whole breast. In that case, we are looking at giving perhaps chemo and as well as targeted therapy or immunotherapy before the surgery. And this is to shrink the tumor so that the surgeon's job is easier and the breast hopefully can be preserved, and the surgery may just be a lumpectomy. After the surgery, sometimes we do complete a chemo and a targeted therapy or radiotherapy, followed once again by radiotherapy and then endocrine therapy. So we'll start with what is chemo? Chemo is the dreaded word that everyone hopes that they will not need for their treatment. So chemotherapy is actually cytotoxic drugs used to destroy the cancer cells, but there are many different types of chemo drugs which can be given in single agent or combination. And majority for early stage cancers are given intravenously, but for advanced stage cancers, some are given in tablet form. And they are given in cycles weekly, 2 or 3 weekly, and the treatment lasts for several months. Why do we use it? Once again, I've explained, post-surgery, when there's no evidence of cancer, it is to mop up any micrometastatic disease. In the neoadjuvant setting, it's to convert an inoperable to operable cancer or facilitate a lumpectomy. And we sometimes give it in the palliative form. It's not really palliative, but it's to control, shrink the cancer and make sure that the patient has an improved quality of life and also a prolonged life. So the side effects of chemo are systemic and affects both the tumor and normal cells. Rapidly dividing cells are more sensitive to chemo. Some patients may have very few, but rest assured, most side effects, especially in early stage cancers, are usually short-term, and the long-term benefits of chemo outweigh the side effects. And most of the side effects of chemo are easily manageable as an outpatient. So this is the treatment area of an example of our clinic, where the patients would sit and have the chemotherapy. And you see this machine here, which I will explain in a bit what it is. So how are the side effects of chemo minimized? We actually minimize it by personalizing the dose according to each person's body surface area and weight. It is administered by experienced staff we do frequent follow-ups and give appropriate medications to counteract the side effects. Hair loss is one of the most feared side effects of any woman, but however, hair loss for chemotherapy is reversible. And that machine I was showing you is actually a scalp cooling machine. There are two types, either Paxman or DigniCap. And what happens is that there is a tight-fitting helmet which is filled with a gel coolant. And the rationale of this is when you wear it during chemo, it constricts your blood vessels in your scalp, resulting in less chemo being delivered to your scalp, decreased follicular cell metabolic rate, and hence, hopefully, less hair loss. It is not for all chemo regimens. Some regimens are more effective than others, has more success rate than others for this cooling cap. There are some conditions patients may have, which may mean you can't use it. But in general, for early stage cancers, for patients on certain chemo regimens, we can consider using it. So how do we decide when chemo is needed? Apart from tumor lymph node, apart from the tumor characteristics, we can also send the tumor for some genomic sequencing. And it is not for all cancers. We usually use it for cancers that are lymph node negative or with only 1 to 3 lymph node positive cancers. And this is an example of a report. And this genomic sequencing actually sequences genes that are most frequently associated with cancer proliferation. And they come up with a score. And this score will then tell you whether your cancer is of high or low risk and whether or not you will benefit from chemo. So there are all these measures to try and reduce giving you chemo if it's not needed. Now we move on to hormone receptor positive cancers. And hormone receptor positive cancers, because if you remember the ERPR is positive, we can actually use oral tablets to try and block these hormone receptors and kill the cancer cells. And it is usually used in early stage or can be used in late stage cancers, and the side effects are generally well tolerated. There are several anti-cancer therapies for hormonal therapy, such as tamoxifen, aromatase inhibitors, used in early and late stage cancers, fulvestrant, which is an injectable form of anti-hormonal therapy used in advanced cancers, and GnRH analogs, which are an injection as well to suppress the ovaries. And this also can be used in early or late stage cancers. Now, although we have such an armamentarium of drugs, very often our cancers do get resistant, and especially in advanced stage cancers, when you use these drugs, after some time, they may stop working. So there has been more and more research on how to overcome these resistance in cancer cells. So one of the newest findings is the drug called CDK4/6 inhibitors. Now, this is a complex diagram, so just simply, this is how hormone receptor positive, one of the pathways that hormone receptor positive cancers can replicate. And CDK4/6 inhibitors inhibit a certain level in the pathway and prevent the cells from cycling through. And what's good about these CDK4/6 inhibitors is that they are oral tablets. So a lot of people like oral tablets rather than intravenous drugs. And initially, they were approved in 2015, started with palbociclib, approved for use in advanced cancers. And over the years, newer drugs like ribociclib and abemaciclib have come into the market as well. And so they have all been approved for use in advanced breast cancers, not alone, but in combination with those aromatase inhibitors and tamoxifen that I talked to you about earlier. So they can't be used as a standalone drug. So, with every research, if a drug works in the advanced setting, then we start investigating whether it works in the early stage setting as well. And this is no different, where further studies showed that abemaciclib actually improved the invasive disease-free survival in high-risk early stage breast cancer. So this is the newest for early stage breast cancers, where we can add on abemaciclib which is one of the CDK4/6 inhibitors, together with your standard endocrine therapy to reduce your risk of recurrence. And this has been approved by the FDA since October 2021. So this is an example of a patient, Madam Z, who is a 33-year-old Chinese female who was actually just diagnosed with metastatic breast cancer to the bones after she delivered her baby. So this is the cancer in the left breast, and this is the cancer that has spread to the bones. And her cancer was ER and PR positive, HER2 negative. And I gave her ribociclib together with letrozole, which is one of the aromatase inhibitors, and leuprolide, which is the injectable anti-hormonal therapy. So what happened? This was in August 2020. And then if you see the scan in November 2020, you can see that her left breast tumor has more or less almost resolved, and her bone spread is lighter. And in January, this is a later scan. Her bone as well as her left breast tumor had resolved, and in other areas of her bony involvement as well, they have resolved. And then she continues to actually lead an active life, and in fact is so well that she was actually thinking of having another child, although that would be risky on this anti-hormonal therapy. So moving on, what do we know about triple negative breast cancer? Now, triple negative breast cancer, if you remember back to the last slide, it was ER, PR, and HER2 all negative. And with that, you know, if you're ER, PR negative, you can't use anti-hormonal therapy. If you're HER2 negative, you can't use targeted therapy. So it used to be that chemotherapy is the only known therapy for this more aggressive type of cancer. But there have been other promising strategies that have come into play, and one is immunotherapy and others such as PARP inhibitors. So for early or locally advanced triple negative cancers, sometimes we use immunotherapy with chemo to shrink it, or after surgery, we can use certain chemotherapy drugs to improve the outcome, such as capecitabine, which is an oral chemotherapy drug. So immunotherapy was first discovered by these two people, James Allison from Memorial Sloan Kettering, as well as Tasuku Hondu from Japan. And they won the Nobel Prize for immunotherapy in 2018. And this has really been a game changer. I think Dr. Lim has explained to you what immunotherapy means. Immunotherapy is actually when you have a tumor cell tricking your immune system and sort of putting blinders on it, such that it thinks that itself, the tumor cell, is part of your own body. What immunotherapy does is it unhinges this blinkers that the tumor cell has put on your immune system, and then causes your immune system to become unblinded and then start to kill your tumor cell. And these immunotherapy are in the form of these anti-PD-L1 or anti-PD-1 drugs. In breast cancer, pembrolizumab is the immunotherapy that we have used in a fair number of cancers. It is an anti-PD-1 inhibitor. And in the neoadjuvant, which means before surgery, when the cancer hasn't spread anywhere else, pembrolizumab has been shown recently to be effective for use in combination with chemotherapy because it improves the pathological complete response, meaning that when the surgeon cuts out your tumor, he or she cannot find any cancer in your tumor sample that is taken out. So that is a very good thing, because if you attain that, it means your long-term prognosis is also better. So pembrolizumab has been shown in this setting to be of use. In the advanced setting as well, immunotherapy such as pembrolizumab has also been shown to be effective with chemotherapy in tumors that express the PD-L1 protein that was mentioned earlier, and they will check this protein on your tumor tissue, okay, and to see whether or not your tumor tissue, your breast tumor is suitable for immunotherapy use, because not all triple negatives can use immunotherapy. So this is a patient, Madam G, who's a 59-year-old Chinese lady. In 1997, she had stage 2 left breast cancer, had surgery with a lumpectomy axillary clearance. She declined chemo at that time, so she received radiotherapy as well as anti-hormonal therapy for 5 years till 2002. Then in August 2020, she developed a recurrent left breast cancer, and the right axillary lymph node was also involved with cancer. Biopsy showed metastatic carcinoma, and I didn't write it here, but she was triple negative. So this is a different kind of cancer from the one she had in 1997. Because she was a triple negative breast cancer, she was given immunotherapy as well as chemotherapy. And at the point of surgery, she had removal of her left breast tissue as well as the right armpit lymph nodes. But thankfully, the cancer hadn't spread to the other parts of the body. And upon removal, after the immuno and chemotherapy, there was no residual cancer left in the tissue that was taken out. So she responded well. And till today, she continues. I just saw her last week, and she continues to be well. And the PET scan has been clear. Immunotherapy, although it's not chemo, does have its fair share of side effects, and because the immune system can affect other parts of the body from head to toe, actually. So it can affect your most commonly like thyroid, lung, colon, where it can present with certain symptoms specific to that organ. But a lot of times, these symptoms can be treated easily and if picked up early. So we do have to be aware of the side effects it can cause and caution the patients as well. So what about PARP inhibitors? PARP inhibitors for triple negative cancer work on the premise that when you have a single-stranded break in your DNA, normally this PARP, which is poly-ADP ribose polymerase, will recruit enzymes to repair this break. But if you do not repair it well, it then progresses to a double-stranded break in your DNA, which in this case still can be repaired by a method known as homologous recombination, the components of which are controlled by this gene called BRCA. But if you have a BRCA mutated cancer, if you are a BRCA mutation carrier, BRCA is an inherited gene. And if you have a mutation in this gene, then you cannot repair this break in double-stranded break in the DNA, and then your cell will die. And therein lies the benefit of PARP inhibitors in this pathway. So these are examples of PARP inhibitors. They are oral drugs. The two on the market are olaparib as well as talazoparib. And olaparib and talazoparib are used for approved for use at the moment for advanced breast cancers who carry, if the patient is tested by a blood test, to have a BRCA mutated gene, which is a gene that is inherited from either your father or mother to the child. And this is done by genetic testing. Recently, olaparib has also been used, approved for use in early stage high-risk breast cancers as well. So lastly, moving on to HER2 positive cancers, 15 to 20% of breast cancers express HER2. And the initial drug that was approved for HER2 positive cancers is Herceptin, which targets the growth promoting protein, which is present in larger than normal amounts on the surface of the cells. It is used both in early as well as late stage cancers with survival benefit, and it is given intravenously traditionally. There was a newer drug that was developed, and it was known as pertuzumab. And pertuzumab works in synergism with trastuzumab, also known as Herceptin. And these two work in order to improve the efficacy of effect of this drug on the breast tumor. They can be used either pre-surgery to shrink the tumor before surgery, And in the post-surgical setting, there is another drug known as TDM1, which is a novel agent, novel formulation rather, which is an antibody drug conjugate. With so what it has is, why it's called an antibody drug conjugate is because trastuzumab, which is the Herceptin, is the antibody. It is linked to the drug, which is a chemo drug known as TDM1. So it brings the chemo drug to the HER2 positive cell and releases the DM1 inside the cell. And so it is the effect of the chemo on surrounding cells is not the same as traditional chemotherapy. So it's very much more well tolerated. I didn't put this in a slide, but apart from TDM1, nowadays for HER2 positive in the arena has been an arena where there have been the most new developments. And there is another antibody drug conjugate known as trastuzumab deruxtecan. And this drug has been showed very promising activity in advanced cancers. And it has a similar formulation. It is called an antibody drug conjugate because it's trastuzumab, which is the Herceptin, as well as deruxtecan, which is the chemotherapy drug. Now, for Herceptin, as well as pertuzumab, nowadays there are subcutaneous formulations that have been approved, and this saves patients time in the clinic because the injection can be given over 5 minutes approximately, although 8 minutes initially for the first one. And so, if you have a phobia about going to clinic already for treatment, it certainly will lessen your anxiety. So this is a patient, 54-year-old Madam A, with metastatic breast cancer to the right breast, as well as involving the liver as well. And she received, I gave her Herceptin, pertuzumab, as well as chemotherapy. And that was in November 2019. In March 2020, post 6 cycles of chemotherapy, her tumor in the breast and the liver have resolved. This bright thing is the heart. This is normal to have. It is not the cancer. And then back up to 2021, December last year, and she continues to do well. And I've seen her recently as well, and she continues to, this is the latest scan that I have, that she continues to have no evidence of disease. So that apart from all these drugs, there are other new developments in HER2 positive cancers, such as oral anti-HER2 agents called tucatinib, but I thought I wouldn't go into such technicalities, and I'm free to answer your questions in the Q&A as well. So for breast cancer surveillance, people often want to know how to prevent the cancer from coming back. So I think everyone knows that exercise is important, as well as maintaining a healthy weight. For dietary factors, alcohol has a consistent link with breast cancer, so one should limit alcohol intake. Fruits and vegetables, studies are inconclusive for breast cancer, but for general health, it is important to have a good diet with more fruits and vegetables. Fiber intake, once again, questionable, but it is good to increase your fiber in the diet as well, and to limit your fat intake. Red meat and processed meat has a link with premenopausal breast cancer in a few studies, but the evidence is weaker than for other cancers, such as colorectal cancer. So this is what I said earlier: maintain a healthy weight, physical activity, and have a good diet. And as well as for bone health, because a lot of the endocrine therapy can affect the bones. So you should keep active, and if necessary, check with your doctor about what other measures to take. And take your calcium, vitamin Ds, limit your alcohol intake, stop smoking. And there are other medicines as well that can help to reverse any osteoporosis that you may have with treatment. Okay, thank you.
Okay, thank you, Dr. Tan and Dr. Lim, for the insightful sharing. And right now, we'll move on to the Q&A session. Should you have any questions, please send your questions in the Q&A tab at the bottom of the Zoom application. So without further ado, let's take some questions from the audience. Okay, let's see. So the first question to both doctors. Does food and water intake cause cancer?
Maybe I'll take this first. I think this is a very general question. I don't think it pertains particularly to the two cancers that we talk about today. So in general, some dietary habits has been shown to increase the risk of cancer, such as eating excessive amount of red meat, processed meat, and the risk is actually increasing the risk of people with colon cancer, okay, or intestinal cancers, and even some stomach cancers. You know, the use of kind of preservative, eating a lot of preserved food may also increase the risk of nose cancer, which is actually a bit more common amongst our Asian community. I think in general, in terms of diet, what then happens is the fact that if there's a kind of overindulgence, and that can also lead to other medical problems such as obesity, which itself is a risk factor for several cancers, such as 1, breast cancer, number 2, in women, womb cancer as well. These two cancers in women are heavily related to weight, right? So that's the importance of meeting an ideal weight, right? Whether it's through diet or through exercise. Okay, so I'm not sure whether Xing Huang, you've got anything else you want to add?
Well, I think that water-wise, water intake shouldn't cause cancer. There's a saying that as you get older, food is poison. But I think, well, although there may be some truth to that statement, but I think it's probably more in terms of, you know, you probably, as you get older, cannot indulge yourself the same way with massive quantities of food and not thinking of what you eat compared to when you are younger. So it's a very broad question, but you know, it's the type of things you eat that would put you at a risk. And you know, not all cancers are food related. And so in fact, a lot of cancers are not food related. But I think in general, if you build up yourself, have a good diet, your immune system is healthy, then it will be able to get rid of, you know, your body's repair, and all that will be better. And then perhaps your long-term outcome for cancers will also be better. So really, there isn't exactly like what food you eat be linked to what cancer for breast cancer. Yeah. For gastrointestinal cancers, things like colorectal cancers, perhaps the type of food like red meat, processed food, all these may cause an increased risk of cancer. So once again, these are general knowledge, things about what's healthy and that. So yeah.
I think when we talk about water, if you consider alcohol to be water as well, then I think you need to take it in moderation, because this can also increase the risk of certain type of cancers, right?
Water as in plain water.
Plain water, yes, fluids.
And I don't think alkaline water, in particular, where people always ask me about alkaline water, whether I should buy an alkaline water machine, really would be anything special compared to just regular water that you buy, off the shelf.
Yeah, I think since we're on this food and nutrition topic, I just received a question like, what's the role of soya and soy products in breast cancer?
So soy products contain, I think the fear of this stems from the fact that soy products contain phytoestrogens. And phytoestrogens may have a structural similarity to intrinsic estrogen in our body, and then there is the fear that sometimes it may bind to the receptors and cause breast cancer. Or the other side of the coin is that it can block the receptors and paradoxically protect one from cancer. I think there is no hard data to show that soy. There are some studies that have shown that if before you have breast cancer, that soy intake may be protective against breast cancer. But the studies are very varied. There are so many. They are done in different countries, and we really don't know the exact amount of soy that needs to be taken, or even needs to be taken at all, to prevent the breast cancer. So I would say everything in moderation is good. It doesn't mean that if you eat a lot of soy that you will definitely not get breast cancer. It can prevent breast cancer. Then on the flip side, people who have breast cancer, so the patients always ask me whether or not they can take soy products. Once again, I think in moderation, if there are natural soy products such as your edamame beans, your tau suan, all these kind of things, if you take it once in a while, it's not going to kill you. Sometimes you get these soy concentrates that are in your vitamins, and when you take a lot of these vitamins, but in the contents there are soy concentrates, and sometimes I tell my patients not to take it, because these are things you may take constantly, and we don't have actually very hard proof, robust evidence that it is of no harm. So I would try to avoid that, but everything in moderation. I don't think that you cut out soy totally from your diet, because we use it as a condiment too.
Okay, thank you, Dr. Lim and Dr. Tan. Okay, so next question I think is for Dr. Lim. How do we prevent recurrence of cervical or womb cancer?
Okay, so to start off with, cervical cancer and womb cancer are two different types of cancers. Okay, there are different causes of these two cancers. They have different treatment. Okay, so I'll probably try to address them separately. For cervical cancer, okay, the best way to prevent the cancer from coming back is to go for good treatment, okay, and treat it very properly the first time round. Right? When you're diagnosed with cancer, go all out and treat it, have proper treatment, and that is the best thing that you can do for yourself to actually reduce or prevent the chance of the cancer coming back. Right? There are no other kind of things that you can do, like for example, special diets, or other things that's actually going to help to reduce the chance of the cancer coming back. However, having said that, we do encourage women after they finish their treatment to actually go for regular follow-up with the doctors for regular checks, just in case if there's any evidence that the cancer can come back, we can actually detect it earlier and get on and treat it. So in terms of womb cancer, what we call uterine cancer, this is a different cancer from cervical cancer. A lot of womb cancer are related, in fact, to having extra estrogen or obesity in the body, a bit like breast cancer risk factors. So in this group of women, right, other than going for good treatment, get yourself properly treated, okay, other things that I always tell patients especially is to actually look after their weight, all right? Try to maintain an ideal body weight, because obesity itself is a risk factor, all right? It actually, the fat cells in the body can actually be converted to estrogen, and that can or may stimulate the cancer cells to come back. So maintaining ideal body weight is actually very important in these women, other than going for regular exercises, good diet, okay, have a good mental health. I think these are all important to actually try to keep ourselves healthy and fit. Not only do we need to actually prevent the cancer from coming back, we also want to prevent ourselves from getting other type of cancers or get other health-related problems such as heart problems, strokes, etc., etc. Yeah, I'm not sure whether that answers your question, Sharon.
Okay, thank you, Dr. Lim. So I hope that answers your question, Sharon. And now we have a next question. It's for Dr. Tan. Does a triple negative breast cancer patient need to remove both breasts as recommended through genetic blood tests?
Okay, so triple negative breast cancer is often spoken, in relation to when someone sees you for triple negative breast cancer, they may discuss with you what we call genetic testing. And why? Because 10% of triple negative cancers may be found to the person may be found to have it through a hereditary means. And how we find that is actually, as what I mentioned in the slides, through a blood test. That test for this gene, which was made famous by the Hollywood actress Angelina Jolie, where she had the BRCA mutation, and hence When you have a BRCA mutation that's tested from your blood test, what it confers on you is a very high lifetime risk of bilateral breast cancer, as high as 70 to 90%. It also confers on you a very high risk of getting ovarian cancer of 10 to 40% lifetime risk. Because of that, she removed both her breasts as well as even the ovaries and tubes, which need to be then discussed with the patient. Because of that, that triple negative cancer is often spoken in relation to hereditary cancers. If you just have a triple negative cancer, but you have tested genetically and you are not found to have a BRCA mutation, then there is no medical indication to remove both breasts. Okay, so yes.
Okay, thank you. I hope that answers your question. Okay, so next question. Okay, so for women who are single and not sexually active but had early breast cancer in remission, is it necessary to go for pap smear or cervical cancer screening?
Okay, so single, not sexually active. So not sexually active, I think two ways to look at it. If a woman has had sexual experience in the past, but currently not sexually active, yes, they still need to go for pap smear screening and HPV testing as per the recommendation. However, if a woman has never ever had any sexual experiences before, then that might not be as necessary. However, we also do know that the HPV, although it is spread by sexual contact, but skin to skin or genitalia to genitalia contact can also cause the spread of these viruses. So I hope that answers your question.
Okay, thank you, Dr. Lim.
Can I add something too? If you've recovered from breast cancer, and I don't know what kind of breast cancer you have, but if you are on the endocrine therapy, tamoxifen, tamoxifen does confer a slightly increased risk of uterine cancer, which is womb cancer. So you need to see a gynecologist at least annually in order to do a surveillance of your womb to make sure that's normal. By an ultrasound. This is by an ultrasound.
Okay, thank you, Dr. Lim and Dr. Tan. So and next question will be, is cluster of cysts can lead to breast cancer? And my mammogram finding is category 3, suggestive of fibroadenomas.
Okay, so to answer the first part of the question, cysts are very common in women. It is very rare that if you do a mammogram that the breast is pristine, perfect, there are no cysts at all, because cysts are very much part and parcel, and it may be hormonally related, and it can come and go according to which part of your cycle you do your breast cancer. So over the years, cysts can appear, disappear, new ones can appear. So the way to determine whether that type of cyst can lead to breast cancer is firstly, you can't determine yourself. So you need to go and see a breast surgeon who will then have the expert eyes to look at your films. But how they look at it is they look at the appearance of the cyst on the scan, and then there are certain warning signs that will tell you that this cyst can be followed up, and you don't need to do any more scans, and that's a benign cyst. There are some cysts that look like, oh, maybe not sure, but follow up in a couple of months. If it's normal, we leave it. And then there are some cysts that we think that, oh, the appearance really looks suspicious. I think it needs a biopsy. So that you have to leave it into the responsibility of your doctor. But always, if you have cysts on the thing, you don't sit on it. You have to bring your films to a specialist who will then look at it and tell you what you need to do next. Your mammogram finding is category 3. I suppose you're referring to BIRATS 3, which is the breast imaging reporting way they divide it. And category 3 means that you got a 0 to 2% or less chance of it being a malignancy. So that is a very good category to have. And furthermore, they have said that it is suggestive of a fibroadenoma, which actually is a benign tumor of the breast, common in younger people. So, however, if you do find that, my advice to you is, and particularly if you don't feel comfortable, you do feel a lump that perhaps is getting bigger and it's bothering you, you really have to see a breast surgeon who will then be able to examine you, perhaps do a follow-up ultrasound and make sure everything is okay. Yeah.
Okay, thank you, Dr. Tan. So our next question would be, what are the short-term and long-term effects of radiation? And then I think Sharon, she also had the question about what are the long-term effects of chemotherapy?
It depends on radiation where. So radiation for cervical cancer and radiation for breast cancer side effects are different.
So perhaps I was thinking could both doctor maybe just share a bit about the impact on different cancer?
Yeah, sure. So radiation for the breast is pretty well tolerated. You can just sometimes the short-term effects is you may get a bit of dry skin, hyperpigmentation over the breast, and you have to apply moisturizer, and oftentimes this will resolve when the radiation stops. The long-term effects sometimes, and they may quote to you like sometimes there is a very, very small risk of cancers over that area, but the risk is single digit. And I mean, in my experience, I've never come across, thankfully, cancer in that area. Yeah. Short-term side effects, sometimes a bit of fatigue as well when you're undergoing radiotherapy. Yeah.
Okay. How about Dr. Lim, would you like to add anything?
Okay, so the treatments when we use radiation to treat cervical cancer, very often this X-rays or radiation rays are actually targeted at the cancers around the pelvic area, and also sometimes with the vaginal area as well. So the area that this radiation covers, includes the intestines. So women may actually notice in the short term, diarrhea as a very common side effect. They may notice that when they pass urine, because there's inflammation in the bladder, there's this urgency that they need to go to toilet to pass urine more commonly. Okay, in terms of the long-term side effects of radiation to that area, this could include, like Dr. Tan said, a very small risk of getting a different type of cancers in the future where the radiation actually targets. But nowadays, the radiation techniques are so much better and it's more improved and a lot more targeted than it was before. And a lot of these side effects actually has been improved and a lot more manageable compared to what it was, say, 20 years ago. Yeah.
Okay. Thank you, Dr. Tan and Dr. Lim. Okay, so the next question is, does HSA approve chemo drugs before treating patients?
Yeah, the drugs are approved before. It is approved at the level first internationally. Like if there is a drug that is FDA approved in America, when it comes to Singapore, then we get HSA approval before it is launched in Singapore. There are some drugs that may not be approved yet, but it can be gotten early if it's already approved in other countries by special access.
Okay, thank you, Dr.
Right,
Tan. Yeah.
HSA approved. Yeah.
Okay, so next one, it's from okay. The question is, for target therapy and immunology therapy treatment, will the type of drugs used be the same for different types of cancer?
I think the type of drugs that are used is largely dependent on the type of cancers that's being used for, but there are some drugs that can be used across different tumor types. So it really depends on the cancer. For example, immunotherapy, like immune checkpoint inhibitors that we talk about in both cervical cancer and breast cancers, there are about, I think, at least 7 of these drugs available in the market now. Some of this are actually specific for certain cancer types, others is common across the different cancer types. Yeah.
Okay, thank you. And then another question is if let's say my hair is curly and brittle after chemo, so how do we treat the cancer after chemo?
Hair is curly and brittle after chemo. I think I've heard my patients tell me that the first growth often is curlier, and then when they cut it again, it's often straighter.
Yeah.
The brittleness, yes, can be there. I believe over time it actually gets better, but definitely, brittle hair should be treated the same way in general. Brittle hair due to chemo or due to weather or whatever, and it's the same thing that you need to moisturize it. Use a gentle shampoo. Avoid the use of hair dryers, which are very damaging to the hair. Avoid the use of your rebonding, your hair straighteners, your relaxers, your coloring for your hair for the time being if you want the hair's health to return. Yeah, although, sometimes after chemo also you do get more gray hairs and you want to color your hair a bit, but I guess you can check with your hair salon to make sure that maybe it's natural products and it's gentler highlights or coloring. Yeah.
Okay. And then so I think this question, yeah, okay, so for Dr. Tan, may I know, may I check what is the long-term and and what is the long-term and not, I guess it's short-term, she's saying short-term. So what's the long-term and short-term side effects of letrozole?
So for letrozole, I think be it shorter term or longer term, one of the main side effects related to it, which patients often have, is some level of joint musculoskeletal side effect, things manifesting as a bit of joint stiffness, which may start off subtly and then get worse. Things like joint stiffness, joint pain, or muscle pain. And the joint stiffness can be in the fingers, where they say they wake up in the morning, it's more stiff, you shake it, it gets better. My knees get a bit more stiff. When I squat, get up, it's a bit more difficult. The other thing we do monitor in terms for letrozole is your bone health, because in the long term, you take it for years, you see, and then sometimes it can cause things like bone weakening in terms of osteopenia and osteoporosis. But once again, taken into perspective, I've never had a patient with a fracture, because you do try and emphasize bone health, take your calcium, your vitamin D, and also bone protecting medications like I mentioned, like your Zometa or your denosumab, which are injections or drips during the course of the treatment. Emphasize on healthy lifestyle, physical weight-bearing activity, have a diet rich in calcium, eat your green leafy vegetables, and fish and stuff, and these will help to improve any side effects and maintain your long-term bone health. Of course, other things like cholesterol, it can cause cholesterol to be high, so you also need to have a healthy diet. And many other small print side effects, which will not cover here.
Thank you, Dr. Tan. Okay, and this question is, what are the side effects that patients face when going through endocrine therapy? Is putting on weight a side effect of this treatment?
Okay, so endocrine therapy, already mentioned the side effects of letrozole. Just now I mentioned is the same for the entire class of endocrine therapy known as the aromatase inhibitors. These are meant for postmenopausal women. So there's the other large group of endocrine, and I'm talking about early breast cancers only, because that's more often encountered in the clinic. So for the early breast cancers, aromatase inhibitors are one group. Then the selective estrogen receptor modulators, under which tamoxifen falls under, is one group. And the question is, what are the side effects, right?
Yes, correct.
The side effects of tamoxifen, because they are given to premenopausal women, they affect the hormone action of, so oftentimes people complain of postmenopausal side effects like your hot flushes. Some people say because of all the hormonal changes, they have some difficulty in sleeping, but this really depends on each person. Sometimes people always ask whether there are mood changes because they're worried. Most people don't have, but this. The other thing is weight gain. People are always worried about weight gain. And the thing is, if you do a literature search, you will find that tamoxifen and weight gain is not related. But some women do say that, after taking tamoxifen, you do gain weight. I guess it all depends also on your lifestyle. So you have to keep active. It has been shown that physical activity and all will help to relieve all these symptoms. So that's for the shorter term for tamoxifen. Sometimes there can be increased vaginal discharge. For the longer term for tamoxifen, there are two things you need to be mindful of, and one is the uterine cancer risk, which is 1 to 2 per 1,000 women per year, that you need to see a gynecologist once a year, and then the other risk of thrombosis for tamoxifen, 1 to 1.5% in your lower limbs, for less than 1% in your lung or brain. So these your doctor will talk to you about it.
Okay, thank you, Dr. Tan. And I think this question is for Dr. Lim. Is someone with endometriosis high risk for cervical cancer?
No.
And
endometriosis refers to a condition whereby what is normally in the lining of your uterus, the cells there has actually migrated outside of uterus, and this can go outside the uterus to affect other parts of the body, the abdomen, or outside the lining of the intestines. So endometriosis per se is not a cancerous condition. It does not lead to increased risk of cervical cancer. I think one of the reasons why the person is actually asking is because of the fact that endometriosis can also cause some of the symptoms which cervical cancer can cause. So for example, pain during sexual intercourse because of the endometriosis per se. However, women with endometriosis, which is actually a very, very common condition, there is a slightly higher risk of getting ovarian cancer. The risk is only slightly higher than women who does not have endometriosis, but it is something to be aware of. So women with endometriosis, I suggest that they may need to get follow up by their gynecologist just in case. Yeah. But it is not related to cervical cancer. If you have all those symptoms, get it checked out.
Okay, thank you, Dr. Lim. Okay, so the next question is, okay, I'm not sure if I understand the term correctly. So it's a C-CURB-B2 is equivocal in biopsies for breast cancer, and is there a need to go ahead for FISH testing? FISH testing.
Yeah. So what this participant is asking is because CRB2 is HER2 that I showed you in the slide, and when we test it, the result can either be positive, negative, or borderline, which is equivocal, and that is the testing where we do it by a specific method called immunohistochemistry. If it is borderline or equivocal by immunohistochemistry, we have to go ahead and send the tumor that we have already biopsied for a fluorescent in situ hybridization, which is a FISH testing. And this is a different method of testing to see whether it's positive or negative. It is important to do it because your HER2 is, number one, it is prognostic. It tells you how aggressive your tumor is. Number two, it tells you what kind of treatment. Your treatment can be quite different if you are FISH positive compared to if you are FISH negative, because if you are FISH positive, you may need the targeted therapy, and that will give you the most benefit for your breast cancer. If you are FISH positive, you don't have targeted therapy, then your outcome may be poorer.
Okay, thank you, Dr. Tan. Okay, so the next question. Okay, I think it's also for Dr. Tan. So could you elaborate on mastectomy and the implications for long-term and short-term recovery and the day-to-day life and routine?
Yeah, so actually these for mastectomy, I think generally after all these breast operations, we really hope that the woman will be able to maintain her lifestyle as she was before. That means she can go for her yoga, her Pilates classes, aerobics classes, all this kind of thing, you know, just look after her kids, drive around, work, all this. And really, it shouldn't hopefully impact on any long-term recovery and make you very like bound to certain activities only. You know, I think for short term, sometimes you really have to get used to that feeling of having a surgical scar over an area, and it is the same for a surgical scar, be it in the abdomen or anything. You know, there's bound to be a bit of discomfort, sometimes some pins and needle sensation, it feels tighter, it doesn't feel normal. But over time plays a big role in helping you to get used to it over time. And I think in the long term, some people, and it's important that you are active and you do move that joint, because if you dare not move and all, sometimes you may get frozen shoulder, stiffness, pain in that area. To a lot of women in the long term also complain of some pins and needles. That's normal, so don't get frightened. Sometimes you may have some numbness in that area because this is normal, because your nerves in the skin are cut, and when they regenerate, they don't regenerate 100% in, it's kind of like a cross wire. So that's why you get your pins and needles or numbness in that area. And sometimes the numbness can extend down to your inner aspect of your arm. You know, I have not seen women really incapacitated from these surgeries. I mean, there are patients who have breast surgery who still go to the golfing range, you know. So yeah, you should try and lead as normal a life and be active. And that's a very important way that you can recover physically and mentally from a traumatic experience of breast cancer.
Thank you, Dr. Tan. And I think there's a question about it's more about diet and nutrition as well. So the question is, I read in Japan that people who eat fish has less chances of getting breast and cervical cancer. Is that true? So I guess both Dr. Tan and Dr. Lim can answer this.
No, for breast, no. I don't think fish can prevent breast or reduce the risk of breast cancer. But it is healthy, like I said, it's healthy food to take in general. Yeah. And different fish have different levels of omega-3 fatty acids, which is also good and good for you.
Yeah, I'm not aware of any benefits from eating fish with regards to cervical cancer, but fish in general is good for our health. So I think that shouldn't stop us from eating fish. Okay.
Yeah. Okay, and then I think the next question will be this participant heard that the breast cancer can easily lead to brain tumor. So is that true?
Breast cancer itself in the general population doesn't lead to brain tumor. Okay, this question can be interpreted in two ways. One, if you have a breast cancer, if it recurs, the brain, apart from the liver, the lung, the bone, the brain is one of the areas that breast cancer can spread, commonly can spread to as well. So yes, in that sense, if it recurs and it chooses an area to spread to, the brain is one of the areas that it can spread to. But if you biopsy the brain tumor there, it is not brain cancer cells, it is still breast cancer cells. So you treat the entire system as for breast cancer. So you're not having two cancers, you're still having one cancer that has spread to the brain. Now, on the flip side, what about two cancers? That means if you have breast cancer and brain cancer, is there a link between, that means you have primary brain, you biopsy it, this is brain tumor cells, primary brain tumor cells. There are certain genetic syndromes, such as Cowden syndrome, where there is a genetic mutation in the PTEN gene that can predispose one to getting an increased risk of breast cancer, brain cancer, thyroid cancer. It's like a syndrome. This is rare. But yeah, I think you're probably referring to the first instance. Yeah.
Okay, thank you. I hope that answers your question. And the next question will be to both Dr. Tan and Dr. Lim. How effective is proton therapy in comparison to normal radiotherapy in breast and cervical cancer?
Not for breast, it's not standard in breast cancer to use proton therapy for adjuvant radiotherapy.
Okay, I think proton therapy is one of the newer ways of radiation treatment, and the advantage of this type of treatment over our standard radiotherapy is the fact that you use protons and it can actually give higher concentration and target the cancer cells better, and you are less likely to damage the surrounding cells. So at the moment, a lot of this type of treatment are focused on using it to treat pediatric cancers, because in children we really want to make sure we don't damage their normal cells, and also cancers near very critical structures such as the brain, the spinal cord, so on and so forth. I think it's been studied in cervical cancer, and we're waiting on the results of these studies. I know in certain big centers in US, this has already been adopted to treat cervical cancers, but I think we're still waiting for further research and further information for us to actually use it as a standard form of treatment in cervical cancer.
Yeah. I think the thing for breast cancer, proton beam therapy has been also studied in some big centers in the US too. But in Singapore, it has yet to become standard.
Yes.
Yeah. But because of its targeted delivery, it is certainly an attractive option. And I think in future, it will probably be part of our treatment. Yeah.
Okay, thank you, Dr. Tan and Dr. Lim. Okay, the next question will be for hormone treatment for breast cancer, does the length of using it depends on the stage of cancer, like longer hormone treatment for later stage of cancer?
Yeah, so hormonal therapy can be used in advanced stage or earlier stages. Like advanced stage means it has gone to other areas of the body, so stage 4. Then it can be used in early stages, stage 1, 2, and 3. For the advanced stage cancers, hormonal therapy, if it's working, we continue as long as it works. For earlier stage cancers like stage 1, 2, and 3, particularly for the later higher risk cancer. So for stage 1, 2, and 3, we normally look at the risk of the cancer. So with stage 3, obviously, is higher risk. Stage 1, lower risk. Stage 2 really is a clinical decision. And we look at not only just purely on stage, but also we look at the biological characteristics, age of the patient, all that to make our decision, because in the old days, it was 5 years of endocrine therapy that was standard. Now, we have moved to 10 years of endocrine therapy in total, but do we offer it for every single patient? No. We offer it for the higher risk cancers and cancers which we deem more likely to recur, and therefore longer is better. So it depends. But 10 years, it is not wrong to have 10 years of endocrine therapy. Yeah, some have 7 years too, or 10, but it's too complex. Yeah, but 5 years is the old standard.
Okay. So another question is, I guess this participant, she went through laparotomy, and so she wanted to find out like what's the advice for treatment for stage 1A breast cancer with invasive cancer 2.6 mm disc, extensive segment of 24 mm and close margin. So is there a need to do mastectomy? She has a few questions like, can I also do laparotomy with AI endocrine therapy only, and what are the chances of recurrence?
Okay, so all right, so this is a very detailed clinical question, which the details of which cannot be addressed here because there are a lot of missing information as well. But in general, I take it that you're considering what kind of surgery to do and the role of endocrine therapy after that, and what are your chances of recurrence. So the type of surgery depends. Firstly, it is a decision of the breast surgeon when they see you, because the type of breast surgery, whether mastectomy or lumpectomy, depends on the size of the tumor, not only the size of the tumor, but the size of the tumor in relation to the breast. So it's the tumor-breast ratio. Because you can have a small tumor, so you have to see whether, and why this is important is because you have to see if you cut it out, whether if you just a lumpectomy and you close it, whether or not it is still, you're able, number one, to get clear margins, number two, whether it's aesthetically pleasing after the surgery, which is very important. Number two, they also look at the location of the tumor in the breast. But nowadays, with many advanced surgical techniques and all, perhaps that is not as important as it used to be earlier. They also, the other thing about mastectomy or lumpectomy is you have to also look at the other parts of the breast to see whether there are other lesions on the mammogram, the MRI, ultrasound, whatever, that the surgeon would have deemed, hey, maybe I'm not very sure if that could, if you do a lumpectomy, after that turns out to be malignant, then you need to go in and cut again. So all these kind of things is a complex decision, which you cannot make a decision on this just on the Q&A here. We really need to review your scans. The surgeon needs to review your scans and all that. And then whether or not you need endocrine therapy, whether you do a lumpectomy or mastectomy, it is not an indication as to whether you need endocrine therapy or not. So it doesn't mean if you do mastectomy, then you don't need your endocrine therapy. Endocrine therapy depends on your ER and PR status. And as long as it is positive, be it a mastectomy or lumpectomy, you will still need endocrine therapy. Your chances of recurrence really depend on your report post-surgery as to how big your tumor is, because sometimes radiological size and surgical size turn out to be different. Also need an assessment of your lymph nodes to see whether or not they are involved. And then we look at the tumor grade as well and all that, and then we come up with and we look at other tumor characteristics as well to decide on what your chances of recurrence are. So it's a bit of a complicated process. Yeah.
Okay, so thank you, Dr. Tan. And I think there are quite a number of breast cancer related questions. So let me just bring up one more. If triple negative breast cancer do not need hormone therapy, what other treatment?
So for triple negative cancer, if it doesn't need hormone therapy, what other kinds of treatment okay, so triple negative cancer, it is not clear from the question whether it's early stage or whether it is advanced stage. So for early stage cancers, as I mentioned in the talk, the treatment can or early or locally advanced. So sometimes if it's locally advanced, we can give chemo and immunotherapy before surgery, followed by immunotherapy after surgery. If it is early stage, you do the surgery first, then we may give chemotherapy after that. We also check the BRCA mutation status, and in certain instances, we may offer adjuvant olaparib, which is the PARP inhibitor, if you are a BRCA mutation carrier and of a higher risk cancer. If you are advanced cancer, then it's chemotherapy or immunotherapy or PARP inhibitors. Yeah, and other targeted therapy. Sometimes we do special genomic sequencing tests to see whether there are other targetable mutations in really situations where we are very hard pressed to find salvage therapy for the patient after they have gone through many, many treatments as well.
Okay, thank you, Dr. Tan. Okay, I think I have a more generic question, like to both doctors. Is it true that we all have cancer cells in our body, just that they are not active yet? Perhaps maybe either Dr. Lim or Dr. Tan can take the question.
What's the question?
So is it true that we all have cancer cells in our body, just that they are not active yet?
I think there are always mutations. I think our body's mutation. There are always in our body. There are a lot of what we call tumor suppressor genes, and these tumor suppressor genes help to keep us from developing tumors at an early age. And this is because as our body the cells divide, sometimes there can be mistakes in cell division. But these mistakes in cell division are corrected. And a cancer occurs if these mistakes in the cell division run amok, or there are more mistakes than the body is able to cope with. And this occurs normally as we get older. As that is why people usually develop cancers at an older age. So it's not because you have tumors that are hiding in your body. But I think, if you have, for example, these tumor suppressor genes that are faulty at birth, or faulty due to environmental influences, also they cannot protect your body from or repair your body from all its mistakes, and then you may develop tumors.
Yeah. Okay, thank you, Dr. Lim. Okay, so the next question, I think I'm not very sure what it is, but let me just read and see whether Dr. Lim or Dr. Tan can interpret this. So the question is, cancerous cell identified in pattern, horizontal or vertical? That's question 23. Is cancerous cell identified in pattern, horizontal or vertical?
I'm not really sure what the question is. Maybe is it possible for the attendee to rephrase it again and just send the question in again?
Okay. So we'll wait for the question to be rephrased and then come back to this again. Okay, so the next question is how risky is ADH at a typical daughter hyperplasia? Sorry, I'm not very sure how should I pronounce that, but I think
Atypical ductal hyperplasia is kind of histological diagnosis where there may be cells that are not cancerous yet, but may look slightly abnormal, and this is found on a biopsy usually. This ADH, once it is found, and if they do deem necessary, it usually is excised as well, because it can be associated with more malignant kind of tumors as well. If you just have atypical ductal hyperplasia alone, it does confer a slightly increased risk of breast cancer compared to the normal population. And then there are certain, and in this case, the doctor may refer you for discussion of certain endocrine preventive strategies, such as the tamoxifen, which I have discussed earlier.
Yeah. Okay, thank you, Doctor. Okay, so the next question is it true that Indians tend to have lumpy breasts? And second question is it medically necessary to remove all cysts? And question 3 is what are the chances that cysts will turn cancerous?
Yeah. Okay. I think lumpy breast is not indigenous to any ethnicity, because anybody, be it Chinese, Malays, or Indians, can have lumpy breasts. It is not medically necessary to remove cysts all the time. So if the cyst looks benign, sometimes the doctors may then decide just to follow up. So the answer to that is no, you don't need to remove all the cysts, because cysts, as I also said, can be totally normal, may come and go. So that is a decision that a surgeon will make with you. What are the chances that the cyst will turn cancerous? Yeah, I think I've answered that earlier on as well. Yeah.
Okay.
I think
if you. Yes. Oh, sorry. Was someone speaking? Okay. So I think one last question. So right now, I guess both Dr. Lim and Dr. Tai probably have shared many informative presentation and information with the audience. And so just to also find out, like, how can they actually get in touch with you?
Yeah. How do we get in touch with me?
how do they get in touch with you for a consultation and make an appointment? Yeah, like to both of you.
Let's say right phone number here, clinic phone. I don't know. Do you want our clinic number, Sharon? Sure, you can give them our clinic number. We are OncoCare Cancer Centre. My clinic is at Gleneagles. The number of which is 67337890. That's our clinic number. Or you can email me actually. Yeah, my email, I think, what am I supposed to type? Yeah, you can call our clinic number is 67337890, or you can email me. Yeah.
Okay, I think our back end support staff, they will help to relay the information. So you can probably drop in your email. So this is referring to Dr. Tan and Dr. Lim, right? You can actually drop in your email, then they will relay to the audience.
Okay. You mean I type my email here?
I think you can send it to the back end.
Okay, I'll just send it to back end. Yeah.
Okay, so thank you very much, Dr. Tan and Dr. Lim, for taking time to share with us this afternoon. And so we have come to the end of the Q&A session and the event. So we hope that you found this talk informative and insightful for you. And once again, we thank you for joining us this Saturday afternoon. Have a great weekend and take care, stay safe.
Thank you.
Bye, everyone.